Okay, thank you all so much for coming. This is episode 3 of RBBBC, the Rights Behind Bars Book Club. For those of us who aren't familiar, Rights Behind Bars, we litigate conditions of confinement cases inside prisons and jails and immigration detention centers. And roughly quarterly, in this new tradition, I've gathered to discuss a book that is pertinent to incarcerated people, their families, their communities, and all of us. And so we are double honored today because, first of all, we're joined by Emily Dufton, who's the author of Addiction Inc.,
Hey.
Medication-Assisted Treatment, and America's Forgotten War on Drugs. Emily is a drug historian. Her first book, which I also read and strongly encourage you to read, it's called Grassroots, a history of the social movements behind marijuana and its criminalization and then decriminalization. Um, and she's followed up with Addiction Inc. on the University of Chicago Press, which is just really fantastic. And we'll get into it, so I won't prattle on too much. But um, both Joey, who I'll introduce in a moment, and I have litigated cases around access to medication-assisted treatment inside prisons and jails, and are familiar with Joey more so than me, the literature in medical research that's the legal research. But here we have somebody taking the toolkit of a historian to talk about the really surprising and interesting twists and turns of that is the story of medication-assisted treatment in America. So very grateful that Emily is here and excited to have her talk about the book. We have a bunch of questions, but doubly honored because my friend, occasional co-counsel Joey Longley, out of the National ACLU, who is in their disability rights project and has their docket focused on the opiate crisis and potential responses to it. And so, as you can imagine, a big part of that is decreasing the many legal barriers to medication-assisted treatment. So, Emily and Joey, welcome to the RBB Book Club.
Thank you so much for having me. It's a real honor to be here, and thank you so much for everyone who's here to talk about this book. I'm really grateful to be here. Thanks.
Yeah, so Joey and I will ask questions. We've got a bunch, and more will pop up. But if we're on a subject and you guys want to chime in, raise your hand, and I'll try to direct traffic a little bit. But we have a relatively small group. It can be a conversation. Our goal is to just learn as much from Emily as we can in this hour. And then one way or the other, we'll set aside some time for questions at the end. So whether or not they happen organically in the flow of conversation. Um, so with all that, Emily, to start at a really pivotal point here, in 1971, we have a press conference coming out of the Nixon administration that a lot of people date as the launch of the war on drugs, um, which we have, a variety of sort of pejorative connotations. We think of punitive policies that have come out of that. And yet, at this same moment, we had this burst of public health focused policies and which allowed maintenance therapy for the first time in 50 years. So what's the story of that moment and what led to it?
Yeah, it's a great time to talk about it right now because it's actually the 55th anniversary plus 1 month and 4 days since Nixon launched his war on drugs on June 17th, 1971. So it's very appropriate to talk about it this summer. 55th anniversary is a good one. And you're right, a lot of people, I think, June 17th, 1971, at least among the drug historians that I hang out with, it kind of lingers in the American imagination as this moment that crystallizes when the war on drugs began. And of course, we all know Richard Nixon, right? Law and Order Richard Nixon, who was campaigned in 1968 on a very anti-crime platform. Of course, he was running after the wave of racial uprisings in the late 1960s, after many assassinations, and he was promising to bring down crime, specifically in American cities, where it really was skyrocketing. But that's not the war that he actually launched in 1971. Now, it's certainly what he was doing prior to that point. From 69 when he entered office up until 1971, he was actually specifically using our beautiful hometown of Washington, D.C. as kind of a national laboratory to experiment with crime cutting techniques, as he put it. So in D.C., because this was before home rule, and this was still when the president actually had almost total control, in Congress, of course, had almost total control over the police force and the city council and things like that. He hired 1,000 new police officers, installed new streetlights, hired more judges. So a lot of the crimes were being prosecuted very, very quickly, and the jails and the prison cells were rapidly filling with human bodies. But it wasn't doing anything to bring down crime. So you have heroin use escalating, crime escalating, and then in the spring of 1971, you have this new horrifying event starting to occur, which is reports of heroin addicted soldiers serving in Vietnam. Now, there were about 300,000 service members serving in Vietnam at the time during an increasingly unpopular and increasingly deadly war. Prior to 1971, they'd mostly been using marijuana, but then the Department of Defense actually cracked down very hard on marijuana use. And soldiers started to turn to heroin instead, which grew for the most part very well in the Golden Triangle. And then it was very easy to get that pure, inexpensive heroin directly to American soldiers serving in Vietnam. And when you're living in a war zone, you kind of want something to take the edge off. And they found heroin did that very well. Also, it was scentless. It didn't smell the way that marijuana does when it's smoked. So there was escalating numbers of service members using it in Vietnam. Two congressmen went over there in April of 1971, realized what was happening, heard reports that between 10 to 15%, maybe up to 50% of soldiers in most of the combat operations were using this drug. Most of them were also suffering from addiction to this drug. And they came back to the United States, released a report in May of 1971, said this is they basically said that heroin was actually a bigger problem for the service member going to Vietnam, a bigger problem even than communism was. And the American media freaked out. There was just this like tsunami of media coverage warning that quote unquote GI junkies were going to come and shoot up your Sunday picnic, right? I mean, this is right after the My Lai massacre. This is after John Kerry was testifying with Vietnam veterans against the war, warning that the war was turning these men into animals who would cut off people's genitals and raise villages and poison water supplies because the war had turned them into these kinds of quote unquote monsters. So Nixon hears this. He obviously has to respond. And between rising rates of heroin use and crime at home, and specifically the threat of GI junkies coming home from abroad, he decided to actually change his tactic. Rather than hiring more police, rather than enforcing more arrests, on June 17th, 1971, he makes this big drug war announcement, and the language is characteristically militant. He calls it a new all-out offensive against quote unquote public enemy number one, which was drug abuse, specifically heroin. But rather than saying we're going to lock everyone up, he actually announces the largest federal investment in addiction treatment in American history. He launches a new executive level office called the Special Action Office for Drug Abuse Prevention, or SAODAP. It just rolls off the tongue, doesn't it? And this was a very powerful office. It was the director of it was going to report directly to Nixon himself. They were going to be in charge of 2/3 of the federal drug budget, if you can imagine that. And they were going to use that money to open addiction treatment clinics nationwide to immediately treat the tens of thousands of people who were using heroin at the time. Now, there aren't a whole lot of treatment options available in 1971. There's not really that many available today, but there were even fewer. It was even more limited in 1971. But the Nixon administration, through SAODAP, started funneling money into things like therapeutic communities, into detox programs, into counseling, and specifically into methadone clinics, which is a very new treatment modality at the time. Maintenance as a concept was very young, or only really kind of gotten its start in about 1965. But nonetheless, the Nixon administration, through the work of two aides, their names were Eagle Bud Crow, which you might know because he did go to jail for the Watergate conspiracy, and Jeff Dunfeld, who really pushed Nixon to embrace methadone specifically as a crime control measure because they had seen it work in other places like Chicago, New York, and DC. And Nixon said, well, I've got to do something because all these media reports make GI junkies seem pretty darn scary. And Sayodap ended up opening hundreds of clinics nationwide between 1971 and 1973. And by 1973, over 72,000 people had voluntarily enrolled in many of these treatment programs. It was mind-blowing to me when I started researching this because I believed like everyone else, I was like, well, it's Nixon. Of course, he's just going to arrest everyone. And then it's like, oh, wow, he actually launched this radical public health experiment from the White House itself. Nothing like that had ever been tried before, and really it's never been tried again.
That's so fascinating. And one of the things that I found really interesting, specifically about the Vietnam part of the equation was, we had this kind of media panic, as you mentioned, about, people coming home. But I would love to hear a little bit more about what you have in the book about the drug testing regime that they did in Vietnam. And I think there's just still a conception today that, if you use heroin once or if you use fentanyl once, you're just going to be addicted for life. But like what ended up happening with the vast majority of the people that used heroin in Vietnam when they came home?
Yeah, that's such a great point, right? Especially in 1971, the belief was that once you started to use opiates, and especially once you got dependent on them, that was a lifelong curse. You were never going to suddenly get that out of your system. This was by far the preeminent scientific and medical belief. But what ended up happening in Vietnam, and then even back in the States when the veterans returned, actually really threw that theory for a loop. So the person who ran SEODAP, and he was sort of plucked out of this program in Chicago. He wasn't given a choice to run SEODAP. They were just like, no, you have to do it now. His name was Dr. Or his name is, he's still alive. His name is Dr. Jerome Jaffe. He lives up the street from us in Columbia, Maryland. He just turned 93 at the beginning of this month. He's kind of my surrogate grandpa now. We became very close over the years I was writing this book. And when he started, before he was brought to be the leader of SEODAP, he did kind of consult the White House a couple of times. They were really concerned about the Vietnam situation. And what he said was, listen, prior to June 1971, if you were caught using drugs or trafficking in drugs or anything like that, the punishment in the military was very severe. Usually it was dishonorable discharge, you would lose all of your money, you would be sent home and not great, potentially face, prison fines and things like that. What Jaffe said to the Pentagon and to Nixon's staff, he said that these huge, really monstrous criminal penalties aren't deferring or aren't deferring people from using these drugs in Vietnam. What would be better would actually be a small but almost inescapable consequence. And urine testing technology at the time was relatively new. The machines were enormous. They were kind of like old computers. They were like the size of a room. But FRAT, free radical assay technique machines, were new, and he was starting to use one in Vietnam. It would test someone's urine and would show if they had used opiates in the past 3 days or so. So what Jaffe said was, rather than, throwing all of these service members in jail or dishonorable discharges or things like that, you should bring a frat machine to Vietnam, start testing all of the soldiers' urine before they're about to leave the country. And if they test negative, they're allowed to go home, no problem. If they test positive, however, rather than just throwing them in jail or, kicking them out of the army, you have to keep them in the country. They have to detox in Vietnam for a week in, 100-degree heat in a barbed wire enclosed place. And then you offer them treatment on the West Coast at a VA hospital when they get back. Now, this was kind of alarming for the Department of Defense, which had cracked down very hard on drug use prior to that point. It was basically decriminalizing military drug use. But the army went for it. The whole military actually went for it. So two frat machines were brought over to Vietnam and they started drug testing soldiers before they left. And what they found really quickly was that once word got out that you wouldn't be able to go home and get your butt out of a war zone right when you're about to finish your year in Vietnam, a lot of people stopped using heroin because the ability to go home was way more important to them than the need to use the drug. So most people actually self-detoxed and didn't continue to use the drug when they got home. For those who had developed a dependency and tested positive and went through the withdrawal in Vietnam and then came back and went through treatment, they found that less than 5% of soldiers continued to use heroin in the United States, and less than 1% continued an active addiction. So, what the Vietnam experiment essentially did was an on the ground form of social and medical science that proved that the human body was not entirely dependent on opioids for life if one began to use them in any kind of situation. Now, of course, a lot of people, I think David Epstein wrote about this in his new book. He said, well, it was the transformation in environment, right? If you're no longer in Vietnam, you're no longer in a war zone, you're no longer dodging bullets, it's a lot easier to not use heroin. But it's a lot easier to not use heroin when you know you're going to be able to go home too. They stopped using when they were in Vietnam. So it showed that it wasn't just the environment, it wasn't just the physical dependency. There are a lot of factors that came in to show that the human body can and does recover from opiate dependency. And that all happened amongst this sort of strange context where, for a brief period, opiate use was decriminalized within the American military, never had been before. And I'm pretty sure it's probably recriminalized at this point again, although I don't know. I should check into that. I shouldn't say those statements if I don't know for sure. But what Vietnam basically did was use these soldiers as guinea pigs for what became a radical experiment in testing how long a human dependency on opiates lasts. And it turns out it is not a lifelong condition as previously thought. So the whole Vietnam experience not only transformed American drug policy, but it really transformed the way American medicine viewed opiate use and proved that recovery is actually functionally very possible.
Yeah, so the bit uh about the purported GI junkies being able to self-detox in Vietnam, I found that fascinating first on the grounds of just upending certain people's expectations of what opiate use actually is, but also independently. I don't know if you guys read this book. It was maybe 15 years ago. Mark Kleiman wrote this book called When Brute Force Fails about the HOPE program in Hawaii, which was this program in the 90s where that the premise was that in probation departments in Hawaii, people were violating probation again and again and again and again. And then at a certain point, the probation officer would get fed up and say, okay, you're violated. And they'd go back to prison for a year. But but it was uncertain when that would happen. And they replaced it with a program that if there was a violation, like a drug test positive or failure to meet an appointment, there would be a certain punishment, but a very short punishment. People would have to spend the weekend in jail, and that got much better results. And that's, I think, disseminated out to American criminal justice about, these current policies we have where the punishment can be very extreme, but also it's uncertain because there are all these different off ramps, should be replaced with something that, is much, much, much more humane, but then also has a higher probability of happening. And so, anyway, I just found that fascinating as like taking that for a spin about 25 years before this study that's had a big effect on American criminal justice. Swift but certain,
Hmm.
cashed out in Vietnam as well. So um, another thing that was very interesting about this, about the GI purported junkies, is that it was this opportunity for some sort of uh, remedy in American policy to drug addiction. But what exactly the Nixon administration was going, they had to do something, but what could they do? That, in the background, there were these, relatively small number of people, both from the aides you talked about um, to people around the country trying to find new ways to adequately treat addiction, who were sort of in the background. And I think as Joey knows better than I do, that oftentimes these opportunities for change come in moments of crisis and are used opportunistically by advocates, but it takes years of work in the background to actually make that possible, often by a relatively small number of people. So Richard Nixon does this in the summer of 1971, but what has been happening around the country in the last 6 or 7 years that that has led this law and order president to say, well, looking at this rationally, methadone clinics are the answer to this problem.
Right. Well, actually, if you even want to go back 50 years earlier, what's really fascinating is that the GI junkie scare is not the first time addicted veterans transformed American drug policy. Back at the end of World War I, which lasted from 1914 to 1918, it also ushered in a brief period where the United States actually had about 44 morphine clinics located across the country. New York, there were a couple in Ohio, Georgia, places like that, because the exact same thing happened. A lot of service members serving in Vietnam, or so, serving in Vietnam, that was not involved in World War One, serving in Europe, were gravely wounded, used morphine to control their pain, and when they came back to the States, they found that they were dependent on it. And of course, this is, 1918, 1919, when America is going through an absolute wave of prohibition, right? We've just passed the 18th Amendment. We've just outlawed alcohol. All other drugs, of course, have been outlawed prior to this point as well. But there was fear of these opiate dependent GIs coming back from Europe and again shooting up Sunday picnics because they were going to go into withdrawal. So this is not very many, right? There's about 44 total. Most of them lasted less than a year because the Bureau of Narcotics and Drugs were very opposed to the operation of these morphine clinics, but they did exist. The longest one actually functioned in Shreveport, Louisiana, and that lasted until 1923. But again, we're going into the 1920s and 1930s, a period of probably the most intense prohibition in American history, when even alcohol wasn't available. And that lasted for the drug historian David Courtwright, who's been a wonderful mentor and inspiration to me. He called it the classic era of narcotic control from about the 1920s to the 1950s, when all drug use was met with one response, and that was criminal justice and law enforcement. There were a few programs available. For example, the Lexington Narcotics Farm was available in Kentucky. That was for drug convicts from east of the Mississippi River. Those west of the Mississippi River went to a similar federal prison hospital in Fort Worth, Texas. But those programs were mostly work programs. You would go and stay there for a while, serve out your sentence, maybe learn how to milk cows or attend some tomato plants or something like that. And the relapse rates, of course, were about 90+%. So this lasted for decades, right? For about 40, 50 years after the closure of the morphine clinics. But then something starts to change in the 1960s. Again, as heroin use starts to rise. During World War II, almost all illicit drug use in the United States dropped. Those international trafficking routes just couldn't happen when you're fighting a war in both the Atlantic and the Pacific. So heroin that was being trafficked to the United States from Europe, that basically disappeared. Any substances coming from Asia basically disappeared as well. But as soon as the war was over, heroin traffic started to pick back up again, and it became especially pronounced in big cities, especially on the East Coast in places like New York. And in the mid 1960s, two doctors, their names were Vincent Dole and Marie Neiswander, they started testing different treatment techniques on the heroin using population there in New York. Because by that point, the drug is very pronounced. Addiction is a very much a visible, epidemic on the street and things like that. And they're concerned, they want to do something to help. They both are associated, Dole first and then Neiswander joins him, with the Rockefeller Institute, one of the preeminent research institutions in the United States. And they had the support of the city. The mayor was very concerned about this. And he wanted to get some kind of assistance to help decrease heroin use and crime that was rocketing within New York City. So Dole and Nicewander, they and also their research assistant Mary Jean Creek, who is about 20 years younger than them, but still deserves, even our junior research assistants deserve a shout out, right? So they bring in two volunteers that Marie Nicewander had known from her work in East Harlem, where she was running a psychiatry clinic. She was a Freudian psychiatrist, and she was trying to help heroin users get over their addictions through Freudian psychiatry. Surprisingly, that did not work very well. So she starts working with Dole and Mary Jean Creek, and they bring in two volunteers. And at first, they just start testing drugs on them. They want to see how long heroin lasts in the human bloodstream. How long does morphine last? And they found that heroin and morphine are very short-acting substances. The euphoria is it spikes, it's high, but it's also very short lasting. So you would go through the process of like the high and then withdrawal very rapidly. And they thought, well, there's not a lot that we can really do with when someone's kind of going through this. It's very difficult to get them into, kind of a stable place. Psychiatry isn't working, psychology isn't working. And then, almost as an experiment, they gave their two volunteers very high doses of a synthetic opioid called methadone. Now, methadone has a fascinating backstory. It was developed in the early 1940s in Germany. It was with a Nazi-aligned Farben industry chemical company. Germany has actually a real history of developing very powerful synthetic opiates because it didn't have that same level of it didn't have the colonial reach into places that were warm enough to grow opium poppies. So it was always developing synthetic opioids. Methadone is a full opioid agonist, which means it fully fills the brain's opioid receptors. But what they realized was that it's very long lasting. That's what makes it so different from heroin or morphine, these poppy derived natural opiates. When they gave their two volunteers a dose of morphine, or excuse me, a dose of methadone, somewhere between 80 and 120 milligrams, they found that their two volunteers didn't go into withdrawal for about 24 hours. And they realized they might have found something here. Maybe if someone is, if you can replace their heroin use with methadone use, if they're not going through those peaks and valleys of withdrawal every day, if they're taking methadone once a day in the morning, like taking your daily vitamin or whatever, that might be able to maintain the person's opiate level. So they're not in withdrawal, they're not miserable, they're not sick, they're not going through all those awful things that happen when you're dependent on opiates and suddenly you no longer have them, but you can actually then go about your day, right? They found that once they dosed their volunteers with a relatively high dose of methadone, they started feeling better. They got out of bed. They wanted to start pursuing their education again. One became a painter. One got their GED, and they realized there might be something to this maintenance concept where, if a body is, and again, this is 1964, 1963, 1964, there is the belief that the human body, once addicted to opiates, remains addicted for the rest of their lives. So maintenance suddenly becomes not only a reasonable thing, but also a very practical way to remove these individuals from the illicit heroin scene, move them away from the illicit crime scene, give them one dose of methadone. By that point, it's generic, it costs about 10 cents a day. And this would be a way to remove people from the criminal element, get them into, a law-abiding citizenship, which is what the mayor of New York was going for. And it completely transformed how the medical industry or the medical field felt about opiate use. They published an article about, well, first they started with their first two volunteers, and then they added about 20 more, and they had 22 people in their methadone maintenance experiment. And they wrote a groundbreaking article in the Journal of the American Medical Association that came out in mid 1965 that kind of blew the lid off of what people had thought about opiates before. Now, it was extraordinarily controversial, of course, right? The idea of giving an opiate to a known opiate user was like, what? Like you're switching, it's like switching, as the saying goes or the analogy goes, it's like switching an alcoholic from gin to beer or something like that. But Dole and Nicewander said this was a real practical and transformative way to deal with the heroin problem and the crime problem. And it transformed their volunteers, all 22 of them. And, of course, they were all carefully selected and screened for any other mental health issues, any other addictions and things like that. And the program was like really intense, right? They lived in the hospital for 6 weeks. They were slowly They were slowly titrated down, so they were, you know, adjusted to the methadone and things like that. But they said in 1965 that this had real possibilities, and it kind of blew the lid off of it. So from that point on, from 65 to 71, in those 6 years, a few other doctors said, this doesn't sound so bad. And they started trying it in small programs in places like DC, in Philadelphia, in Minnesota, in Baltimore, in Chicago. And by 1970, there were 9,000 people on methadone maintenance in the United States and Canada, all told. And all of them were doing fairly well in these small, very organized, very kind of selective programs. But that was prior to Nixon saying, "Hey, why don't we nationalize this program and put a whole lot more people on it?" But between, you know, from the morphine clinics of the 1920s to 1970, when Dolan Nicewander said, "This is a real possibility. This can actually happen, and it's incredibly helpful." And all of a sudden, you had about 9,000 people using methadone to overcome their heroin addictions and go on and live those law-abiding, tax-paying lives that that all the political leaders were really hoping to achieve with this form of medication. So it was a really extraordinary journey between, you know, 1920 and 1970, 50 years of like law and order, and then all of a sudden it's like, oh, we can actually medicate this.
Yeah, and one of the things that I found really interesting about that period is how much, at least in the 20s, there's I guess really, I guess by the time it was the 30s, there's really no legal ambiguity. The IRS was going after people that were doing maintenance, attempting to do maintenance, and by the time you get to Dolan Nicewander, I mean it's really like an unclear kind of legal landscape of like, can we do this? And it reminds me a lot of today, with programs like overdose prevention centers that exist in New York. There's two of them in New York. There's a state sanctioned one in Rhode Island where people can go inside and under supervision of trained staff use illegal drugs, and it's a lot less likely that they're going to die of an overdose, and they can get connected to resources, and have seen a lot of promising data out of these kind of programs. And I'm just wondering if this is kind of a pattern that you see of like it's very unclear whether those things are we're in legal ambiguity at best, for the existence, and the federal government's approval of overdose prevention centers today. And I wonder if you see parallels to what was happening with Dolan Nicewander in the 60s.
Oh, totally. Absolutely. I think that's a really good analogy. Although I would say that Dolan Nicewander's methods were adopted relatively quickly, and yet we remain really opposed to overdose prevention sites, which kind of blows my mind because I very much support overdose prevention sites. I think they're actually a brilliant idea, and they're used very effectively in other countries. I wrote about Switzerland and its treatment techniques towards the end of my book, and maybe we'll have a chance to talk about that as well. But there's there is such a strong moral opposition to overdose prevention sites. And I see that same moral opposition against methadone use, even especially in like the early 1970s, 1960s, and then into the 80s and 90s and things like that. Even today, actually, methadone has such a strong stigma around it, and people are so functionally opposed to it. It's very difficult to open clinics. It's very difficult to find people who want to run them. At this point, a lot of them are operated far more as businesses, which is why I call my book Addiction Inc., as opposed to true healthcare organizations. Now, there are some really wonderful programs in the United States, and I don't want to discount them. Actually, there's a lot around here, especially in Baltimore. I've gone to a lot of those as well. But the moral opposition to using drugs, to giving people drugs to simply to prevent withdrawal, or allowing them to use drugs in a place where overdoses can be prevented or they can be connected to larger resources and larger healthcare, that remains so strong. And I don't quite know why the United States refuses to overcome this stigma and opposition, whereas in other countries, even in places that are way more conservative than we are, like Switzerland's a really conservative country, but they have embraced things like methadone maintenance. They also offer heroin maintenance for people for whom methadone doesn't work. They also offer a wide variety of other maintenance drugs. They offer overdose prevention sites, all within a larger suite of treatment options. Whereas in the United States, I feel like we constantly bifurcate between harm reduction and treatment, which is over here, and law enforcement, which is over here, and never the twain shall meet. Like very rarely do we actually incorporate all of those things, plus larger prevention efforts, plus larger treatment options and things like that. It's a real issue for the United States. We just can't get over this hurdle, and I don't know why. More people should read my book, and I think maybe that'll solve the problem.
I think that's it. I think that's holding everybody
Right?
back. I in the chapter about Switzerland is very interesting, and there was to me, talking about never the twain shall meet. There's a very enlightening anecdote where it's mentioned that when somebody who's on maintenance in Switzerland is arrested, the police swing them by the clinic so that
Yeah.
they can make sure that they get their dose before going into jail. Where as as Joey and I know, that is not the experience of incarcerated people in the United States. It's um, to put it very mildly, and we have these institutions that really are antagonistic to one another. My question, which maybe you've already answered just now with I don't know, is something that's really striking about seeing the internal debates about maintenance in the late 60s is that setting aside some of the technocratic details of maintenance, the core argument against maintenance then seems to be the exact same as the core argument against it now, which is this sort of moralistic, you're swapping out one drug for another. Um, I'm curious what is the staying power? What is the root of the staying power of that argument? And is uh, is there some truth in it, you think? Is it just wrong on the data and it needs to be gradually overcome? Like what do we do with this argument that it managed to persuade a lot of people in the 1960s and a lot of people ever since to present?
It's incredible, right? That there's just this like hang up, like the idea of giving someone a legal opioid simply to prevent them from going through withdrawal if they are dependent on opioids. It's like a bridge too far for a lot of people to cross, which is very surprising to me. And actually, even people I know who use drugs are reticent to get on methadone or buprenorphine because there's also a lot of rumors about these drugs, right? Like it's harder to withdraw from buprenorphine or it's harder to withdraw from methadone than it is from fentanyl or heroin. It gets into your bones. That was like a big one, especially in the 1970s. Methadone gets into your bones. I mean, they are opioids, right? And all opioids have side effects. So you might have constipation, you might have sexual dysfunction, you might have anhedonia, which is the inability to feel joy or happiness. But are these drugs easier to or harder to detox from than fentanyl or heroin? Like, no, they most certainly are not. And of course, you're also getting these from trained professionals. These are not going to be adulterated substances that you might get on the street and you don't know what's in them. You don't know how potent they are. Ideally, they're in a nice, professional, gracious, and stable medical setting where you can also be, connected with other forms of treatment and healthcare and things like that. But there's fear and there's stigma that have been around all of these substances basically for their entire lives. And that's something that I personally can't quite wrap my head around. I'm on a thyroid medication. I have to take it every morning. I've been taking it every morning for 16 years, and I will continue to take it every morning for the rest of my life because my thyroid just doesn't work, right? Otherwise, all my hair would fall out, and I don't have much anyway. So I'm trying to hold on to what I have. But no one bothers me about this. There's no stigma or judgment about it. I go to CVS every 3 months and I pick up my pills that cost less than $5, right? There are ways that people are on maintenance programs. I'm on a thyroid maintenance program But that's not the way that people on methadone or buprenorphine are treated. And in a lot of ways, that's primarily because of what methadone became. So if we just step back for a minute and talk a little bit about what happened in the early 1970s, which is basically that the Nixon administration, through SAODAP, threw a lot of its weight and money behind treatment, which I still think was a good thing. But the programs were opened extraordinarily rapidly, often with very little oversight. And I mean, for the abstinence-based programs, if there's not a lot of oversight, I mean, some of the programs were, I mean, I would call them traumatic and abusive and horrific. It's a lot of therapeutic communities are mostly about destroying someone's personality and trying to build them back up. And I don't know about the I don't know about the record on programs like that for keeping people off of substances, but the methadone programs specifically, a lot of them became kind of a little bit cash and carry, right? So the federal government was paying for all of these federally sponsored programs, but a lot of private doctors also started getting into the game and they just started selling methadone. And methadone, as we said, is an opioid. If you are an opioid naive person, about 30 milligrams is enough to cause you to overdose and potentially die. It's not like a this isn't a drug to mess around with. It's no joke. And so between programs that weren't doing a really great job on offering kind of holistic care, they were just dispensing the methadone, between private doctors who were selling the drug, and between a lot of vocal community opposition, people who did not like these clinics, they didn't want them in their neighborhoods. There was a very strong crackdown on methadone maintenance starting in 1973 and in 1974 when private physicians were no longer allowed to simply dispense the drug for maintenance. All of the programs that did want to continue to provide methadone for maintenance had to register with the federal government and abide by extraordinarily strict regulations that, for the most part, required patients to arrive every single day to dose. Oftentimes early in the morning, becomes very difficult to carry on a job or things like that. If your clinic is far away, you have to get there by 6 a.m. or you have to get there certainly at least by 10 to dose every single day. It doesn't matter if it's Christmas, doesn't matter if it's your birthday, doesn't matter if the clinic's in a really seedy part of town you don't want to go to, or if you're in a rural area, it's an hour away. You have to be there or you are going to be thrown into withdrawal, right? And those same regulations actually continue to affect methadone to this very day. They remain almost fundamentally unchanged. And in a lot of states, the regulations are even more strict, right? So some patients are able to earn take-home doses. Oftentimes it can take up to 2 years to get a decent number of take-home doses. That shifted during the pandemic. We can talk about that. But a lot of states actually override federal regulations and continue to demand patients to show up every single day. So methadone became not only stigmatized, but also just very just a pain to go get, right? If I had to go to CVS every single morning to take my thyroid pill, I think I just let my hair fall out. Be like, okay, well, screw it. Who needs it? So not only are these drugs stigmatized, but the systems that they exist in are oftentimes exploitative and punitive. So that's sort of one of the things that also makes, I think, a lot of people look at methadone and say, what is this? Like, we don't support this. We don't like this. And again, this is not how a lot of other countries operate. This is not how it works in places like Switzerland, in places like Australia, in places like England, in places like Portugal, where they have a much easier way to access these medications because they are indeed life-saving. I mean, even the director of the National Institute on Drug Abuse, Nora Volkov, she said that if methadone and buprenorphine, which is a similar partial opioid agonist for maintenance, if they were more available, our horrific overdose rate could be cut by up to 50%. And yet, even as we went through several years in a row with over 100,000 overdoses a year, not all of which came from opioids, but about 70% of them did, we continue to keep drugs like methadone and buprenorphine kind of under lock and key, making them less available and increasingly more suspicious, which is why I think Americans still have a really hard time accepting these medications as sort of a foundational part of American healthcare, especially for people who use drugs.
Yeah, and it feels like the other part of this, which you referred to earlier, is the kind of private business component of this. And I just remember when I started doing litigation in this space around expanding access to MAT in jails and prisons in 2019. And when my Google searches started being really focused on Matt jail, Matt prison,
Mm.
um, I would get a lot of banner ads from Al Kermes advertising Vivitrol in jails and prisons and in criminal justice settings. And it was, it's really interesting. You have some in the book about alchemies and the work that they've done, with drug courts and, Vivitrol is, naltrexone is the medication, and it's a opioid antagonist, so it works differently than the agonist and partial agonist methadone and buprenorphine. And people who are using it really can't use other opioids. And you talk, a lot in the book about how that kind of fits the criminal justice kind of mindset, the traditional criminal justice kind of mindset. So can you talk a little bit just about that intersection of business and criminal justice and the consequences that that's had on people with opioid use disorder?
Yeah, absolutely. So just to backtrack a little bit, naltrexone is really interesting, and I fully support the use of naltrexone too. Like I'm a big fan of all three of the drugs that make up medication-assisted treatment in the U.S. today. They're the three FDA-approved drugs: are methadone, buprenorphine, and naltrexone. And so, as you said, methadone and buprenorphine are agonists, which means they fill the brain's opioid receptors. Naltrexone is really interesting because it's the opioid antagonist, which means that it actually sort of blocks the brain's opioid receptors. It almost acts as a prophylactic. So if someone is on naltrexone, either the daily pill, which was first released in 1984, or Vivitrol, which is a long-acting shot of naltrexone. It lasts about 28 days or a month. That means that their brain's opioid receptors are essentially protected from the use of other opioids. Like you could inject $500 worth of heroin and you wouldn't feel anything. But you have to be fully detoxed from opioids before you either take that pill or get the Vivitrol shot, or else it is going to send you directly into withdrawal and you are going to be really unhappy. But you can think about naltrexone as kind of a longer acting form of naloxone or Narcan. Like if someone is overdosing and you give them a dose of Narcan, it's an opioid antagonist that knocks all of the opioids out of their brain, reverses the overdose, and like Lazarus from the dead, they return from the overdose. Naltrexone is a longer acting form of naloxone, basically. It will kick all the opioids out of the brain and then shield those brain's opioid receptors either for a day if you take the naltrexone pill or a month if you take the shot. Now, it has never been as popular as methadone or buprenorphine for the most part because patients don't necessarily want to go through this full withdrawal to get onto it. So adherence is like a really hard part of naltrexone treatment, but it has become extremely popular in places like law enforcement and drug courts and in the criminal justice system because it does enforce sobriety, it does enforce abstinence, and because the American criminal justice system generally looks down upon opioid use, that seems to be something that they favor. It's still MAT, it's still FDA approved, it's still the gold standard of treatment, but it's one that enforces sobriety rather than perpetuates opioid use. And Alkermes, which is the small Massachusetts-based pharmaceutical company that manufactures Vivitrol and has been doing so, I think, since 2010, since it got its FDA approval, they have actually partnered with drug courts and Medicare systems and police and jail systems in numerous states to have the Vivitrol kind of be the only medication available for this population. Now, when someone's being released from prison or jail, and they've been detoxed and they're going back on the street and they don't necessarily know what's out there, I don't think that Vivitrol is a bad thing. I think it does protect them for that month, and you're protected from overdose because I think, as we all know, upon release from jail or prison, that's one of the most prominent times for someone to die of an overdose, right? Because you're detox, you're not used to it, your tolerance is really low. Naltrexone and Vivitrol can really help in situations like that, but forcing people to take it, forcing them to, abide by this drug regimen that they might not want or necessarily need, I don't think works very well. But it's a business decision, right? Alkermes wants to sell this drug in the same way that methadone has also become a bit of a business decision, right? It's a lot of the private companies, a lot of them are private equity companies that have moved in very strongly into the methadone field. In the same way they're moving into dermatologists' offices, pediatric centers, emergency rooms. What's the word? Oh, I forget, forgetting, one of the other things, but a lot of private equity is moving into this field because you have consistent payments, right? The person's coming in every single day. You can bill Medicaid for their dose, you can bill them for counseling sessions. Like when someone is on a drug regimen that has very strong regulations, forcing people to essentially, take their drug every day or come in every or once a month to get their shot or things like that, these these patients become very profitable, right? Because you are cashing that check every single time they walk across the door, which is also one of the reasons why they're not necessarily getting a lot of take-home doses either. Because if you just hand out the medication once a week or twice a week or once a month, you're getting significantly fewer reimbursements from Medicaid or Medicare or any of the other reimbursement programs than you would if they were walking in every single day. So law enforcement organizations, private equity, like a lot of these sort of business oriented, they're looking for, how to kind of earn money off of this stuff. They're moving into this field because they find it to be lucrative and sustainable. Because if you're on methadone, you're going to be there every day, and you're probably going to be there every day for a number of years, unless, of course, you either go back to the illicit substances on the street or you titrate down and you're no longer on methadone. But that's still going to take a lot of time. So it's a very lucrative opportunity for a lot of very shady people who don't necessarily want to offer actual holistic, stable, and gracious care, which is deeply unfortunate.
So I'd be, I have a bunch more questions. Uh, I'm sure Joey does too. And I'm glad that, all three of us are in the Washington, D.C. area. I'm glad that Joey and I both have lightning strikes going on in the background. Just to add, if you thought this wasn't an exciting, dangerous conversation, that's not a fact. That's real. Um, I, I would like to take the opportunity if there's anybody who would like to ask Emily a question while we're so lucky to have her. If anybody just wants to hit the raise hand button, you call on them. And if not, we've got some more.
We didn't even talk about buprenorphine yet and Suboxone and like all of that
I
good stuff.
I know that's what Jackson.
Hi there. Thanks for the chat. This has been really fascinating and engaging and also deeply terrifying in terms of some of the forces at play. I just had a question around really the last part of that conversation, which is, it seems like there's so many forces that are kind of aligned to, make money off of this. What's the unified forces on the other side that are doing that can make a difference in reducing the kind of profits people are making on this so that they can get that kind of holistic care that you're talking about.
That's a great question, right? And that's sort of where like the SEODAP model, I wish it had continued in a certain way, right? Like I understand that there were a lot of problems with opening these clinics so rapidly and scaling them up so quickly, but there's essentially a nationalized healthcare system for people who use drugs for a brief period in the United States, which is kind of mind-blowing, where treatment was available and it was free and it was accessible. Now, there are certain places where that kind of treatment is still available. We saw this change with the Mental Health Parity Act in, I think, oh God, that was probably in the early 2010s. And then, of course, with the passage of the ACA, the Affordable Care Act, which made treatment more available and more affordable for a growing number of people. Then during the Biden administration, there was a lot of money put into making MAT drugs available as well. But just money isn't quite the response, right? There does need to be a foundational organizational component too, where you have clinics that are open, that are accessible, that people can reach, that people can go to. Now, states have also made a whole lot of money available. I was going to a clinic, kind of a suite of clinics actually in St. Louis, Missouri for a number of years, which have used state and federal funds and are now going to use a lot of the opioid settlement funds, which are starting to be paid out and will be paid out now for the next 15 to 18 years or so, to build a really amazing collection of clinics that offer buprenorphine and naltrexone. They're not registered as a methadone clinic, but they offer buprenorphine and naltrexone. They offer counseling, they offer telehealth, they offer sober housing, they offer work, they offer mobile methadone clinics or mobile treatment clinics. They partner with local churches. They opened this one clinic in an utterly dilapidated area of North St. Louis, not far from where Michael Brown was shot down and killed, that also offers a pharmacy. And it's the first pharmacy that opened in that neighborhood in decades, right? And the local community was thrilled because not only are they distributing Suboxone and naltrexone, but also you can get your thyroid pills or your heart medication or whatever else. So there are ways to make this happen, right? To make this care affordable and available. And the money is kind of there, honestly, between state and federal funds. Maybe not so much now when Medicaid is being decimated before our very eyes. But there are ways to use the remaining money to actually build these systems of care. What it requires are people to enter into the field who are not private equity, crypto bros or whatever, trying to go in and simply make as much money off of this field as possible. But that also requires education. It requires winning over hearts and minds. I mean, as late as 2018, now I know that this is like 8 years ago, it's almost a decade, but as late as 18, in research that I found, only 15 of the country's 180 medical schools even taught addiction medicine. Right. So we have hurdles to get over as well, and simply training enough doctors and nurse practitioners and nurses to even enter the field and understand what it is. So it would require a real revolution in training, in making, in increasing the number of people who are able and competent enough to actually increase access to this field, and then, having people open it. I think there's a lot of options or opportunities with FQHCs, federally qualified health centers, to include a lot of behavioral health components and access to these drugs and this treatment in places like that. But again, it's kind of like a matter of getting on the ground and actually talking to people and getting them to open places and getting them to make treatment available. One of the good things that happened in, I get the year right, about 2023, was that Biden signed legislation that got rid of the X waiver. I know we haven't really talked about buprenorphine, but buprenorphine is different than methadone in that it's actually allowed to be prescribed by a private physician and distributed by a private pharmacy. But prior to 2023, you had to pass like an 8-hour exam, register with the DEA, and get something called the X waiver. And only then were you allowed to prescribe buprenorphine for maintenance. In 2023, Biden got rid of the X waiver. Now, anyone with a DEA controlled substance license can prescribe buprenorphine for maintenance. But again, a lot of private practitioners, general practitioners, they don't necessarily want to take on people who use drugs and people with opioid use disorder. They're considered disruptive patients. They don't want them in their waiting room with like the mom with the kid with the ear infection and things like that. So there needs to be, like, I do believe actually that there's a really strong role specifically for addiction treatment clinics throughout the United States, but they need the staff, they need the funding, and they need the belief that they can make these things really functional, warm, holistic, stable, and gracious places. So again, I just think everyone should read my book, and then we'll just have a wave of people entering the field, I'm sure.
I think, and this is not to be romantic about the ability of litigation to institution build, because that's one of its perils. Like, it can't do that. But in terms of when a lot of this restrictions and the failures to provide medication assisted treatment to people, for example, who are in jail and therefore cannot self-protect, cannot get to a clinic, but are at, the state has decided to separate them from their families and their normal healthcare providers. Or this is work that Joey does when there are sort of animus-based restrictions on the availability of MAT, the arguments that these violate disability law or other aspects of federal law. Again, not nearly enough, but eliminating some of these real like outlier egregious situations like nudges us towards this world where treatment is more widely available and as Emily said so beautifully earlier, gets us out of some of this negative feedback effect where there's stigma around clinics. And so clinics aren't allowed to be opened and they're a mess. And so that creates even more stigma around clinics, right? Um, so we need to be start, nudging these things towards the positive feedback effects instead of the negative.
Right. I mean, it can be a really, I mean, some of the people I've talked to who work in this field say that it's the most satisfying job they could ever imagine because you really have the opportunity to watch people transform and you have the opportunity to change their lives for the better. I mean, addiction is not a comfortable life. And I think we have to remember that. I mean, some people think, well, they're using drugs because they want to, and they're never going to stop. And it's like, no, active addiction, chaotic addiction is a really miserable life. And to bring someone, kind of back from the brink of that chaos to allow them to return to their families, return to their homes, right? That's actually a really beautiful and powerful job. The burnout rate is high. The turnover rate is high. The money ain't great, right? But if we could build a system that would actually support not only the patients but also the people working in the field, like I mean, it's a groundbreaking and really wonderful field to work in if you like people and you like helping them and you like to watch lives transform for the better. Um, but that's not what we hear when we talk about MAT or when we talk about opioid use and people who use drugs. It's the negative stories outweigh and outnumber the positive ones overwhelmingly. And I think that does a lot to kind of keep people away from the field, to keep the field in this land of stigma and degradation. But it doesn't have to be that way. It's not that way in a lot of other countries. And if you'd think 100,000 overdose deaths for like 4 years in a row would have pushed us to transform a little bit more rapidly. It has not yet, but I have faith in humanity, and I do think it's possible if we increase the education about it and increase the examples. Like if you can see how a good clinic operates, and you can realize that it can be economically very sustainable, especially with the amount of funding that's being funneled into the field. It's not impossible. It's not outside of the scope of reality. It is happening here in small doses in the US, and it's certainly happening abroad. And the potential is there. We just kind of need the imagination and the compassion to actually do it. And what shocks me is that, like, the KFF News found that 1 in 3 American adults either knows someone or themselves has opioid use disorder. I mean, this is a problem that touches every single one of us. And if it doesn't touch you, it touches your partner, or it touches your friend, or it touches your coworker. Like everyone's affected by this. I think if we were more open about it and we were a little bit more honest about it, and we realized that, if you have a loved one who has this problem, you would want them to have decent, holistic, and sustainable care too. And may we all have access to such things at some point in the future. Maybe Jerry Jaffe's dream will come true. Or maybe Nixon's dream. I don't know what we should say.
I I think as a general matter, we don't really want Nixon's dreams to come true. I think
Maybe
we
not.
should.
But Jerry Jaffe's great, so how about him?
Yeah, sure. Let's take him. I just not just that living in a cruel world. I just think it would be a strange world. If we were in Nixon's dream world,
What
weird
would
stuff
that
would be
be?
going on. I think um, uh, we've gone a hair over,
Yeah.
but but this has been so great. Maybe if Emily was so kind, if anybody has a final question. Or if not, I think we can wrap there. Um, and yeah, like Elizabeth just said in the chat, I uh, really strongly recommend the book. I strongly recommend Grassroots, which is Emily's first book, and available at People's Book, finance bookstore in Tacoma Park, Maryland. You could even probably get a signed copy there. Um, or wherever books are sold. There's an audiobook if that's how you prefer to consume. Did you read it?
I did. I believe it's 15 hours and 19 minutes, although it was longer than
Okay.
that to record it. But if you'd like to hear my voice in your
Yeah.
earlobes for for a whole long time, you
Right.
can get the audiobook too.
If these 66 minutes were just so intoxicating, you could just keep the experience going. Um,
You did a beautiful job reading. It was really good.
Oh, thank you. Oh, thanks.
yeah, Phoebe listened to the audiobook and she said it was great.
Nice.
Um, so yeah, I just want to thank thank you, Emily, for taking the time to speak with us. Thank you for your work. And thank you also to Joey. I didn't dwell on Joey because we're talking about Emily's book, but uh, Joey's work and advocacy around really a wide range um, of uh, legal issues coming out of the opiate crisis, bringing that disability rights lens into the National ACLU and litigating cases around the country, is just fantastic. It's a privilege to get to speak with him about this, and I'm glad he could bring his expertise to this conversation. So thank you both so much.
I so appreciate the opportunity. Thank you so much. And thank you for the work that the both of you do as well. It's really crucial and important. And it's an honor to join you for this wonderful evening, even as the rain is pouring outside.
Awesome. Yeah, thank you, Emily, and thank you, Sam, for having me. This conversation, you say this in the intro to the book, Emily, it's just like not talked about enough. And just like the field of addiction medicine, it's just kind of like a little bit, seen as below. I think this conversation, elevating this conversation is so, so important. And like you said, it's so rewarding and life-saving. So really glad to be able to be a part of this conversation.